at least here at UCLA, we are very limited by the patient's funding resources. They have different types of health insurance, they have different things that are covered. So we have to design a program that, you know, will fit with what their healthcare funding is. You know, my center used to be a multidisciplinary post-polio center. Changes in funding, you know, resulted in us becoming a center without walls. So we do a lot of networking within UCLA and in the community to find resources that we can rely on. So, you know, we have a long list of pools that could be used by people with handicaps and what their temperatures are and how accessible they are. We have a list of community orthotists and community occupational therapists and physical therapists so that, you know, we can respect, you know, the problems with travel and transportation in general, and also the problems with funding.
Kind of an important thing that I find is that not all post-polio clinics are the same. It really depends, I think, on the leadership of that clinic, what how the patients are evaluated. Now, Rancho, because of Dr. Perry's orthopedic background, it's very much orthopedically, mechanically, kind of, that's where our strength is. Now, other centers probably do some bracing as well and so forth, but in terms of you know, having these kind of orthopedic types of perspective on polio, I think this is probably one of the very unique centers that they have. I think what I kind of add to it a little bit is because of my rehab and internal medicine background. You know, that adds a little different flavor to it as well, where we talk about pulmonary issues and things like that. We're able to offer that. And again, it's a little different than probably a polio center run by a neurologist, because they also come from a different perspective.
Yes, we were at UCLA yesterday meeting Dr. Perlman. Yeah.
Right. So, so yeah, I think so. I guess my point is that polio clinics are not the same. It really depends on who is sort of the philosophy behind how they treat polio, and I think each center has sort of their unique strength. And I think our strength is really in terms of maintaining and improving function, and just an orthopedic perspective of looking at gait, normalizing gait as much as we can. Our clinic is extremely strong, and I think we provide the best care in terms of analyzing their gait, normalizing it, understanding the reasoning behind why they walk the way they do, and that's very important, because if you walk kind of funny, you compensate by using back muscles, you know, and then you use shoulder muscles, and then everything kind of, you know, falls apart from there. So we really get to the root of the problem and correct the issues that actually will help multiple of other issues. So somebody comes in and says, I have back pain, and we give them a brace. It's like, okay, how is that related? But you know, when they come back, well, you know, voila, their back pain is better, because they corrected how they walked. So the resident and the physical therapist, they both go in. That probably takes, I would say, anywhere from 30 to 40 minutes, and then we all discuss together as a team.
Including the polio patient?
Yes, well, we first have a pre-discussion, you'll be able to see that, and then we actually go all together as a team, include the patient in the discussion. We do the observational gait analysis together, then we make our recommendations, and then an occupational therapist goes in and she does the counseling on lifestyle modification, and so the whole process, I would say, probably takes at least a couple hours, but there's kind of breaks in between, because we're seeing other patients as well, so but I think if you put it all together, probably a couple hours. I think the unique aspect is that you know, not too many polio clinics have access to the orthopedic surgeons at their fingertips. So here, basically, if we say, you know, a brace is needed for this patient to improve function, but the person has some sort of a deformity of the foot or the leg or something that cannot tolerate the brace, and then we have the orthopedic surgeon who basically says, you know, we can do this, we can correct this, and then we could then, you know, put the brace on, and then, and so we have this whole picture, whereas probably in other areas where they don't have an orthopedic surgeon who's actually running the clinic would have to then refer somebody to an orthopedic surgeon who might not have a full idea as to, okay, why are they doing that, and it's not really part of the team, so I think those are kind of the features.
We talked about muscle testing. Muscle testing is very important in this institution. We work very hard to get accurate. Because muscle testing is hard work. If you just do this, that's not fair plus. That's
Yes, yeah.
And so we use our muscle test as a guideline.
And EMG?
No, I use EMG if I have a question I can't answer clinically. You don't use it very often. It's a gate usually or opportunity.
Yeah, one of the things that we educate our residents about doing muscle testing and so forth is that we really emphasize the muscle testing as not only to see if there's a connection between the nerve and the muscle, but we're wanting to see, does this person have enough strength and capacity to perform function? And it's a totally different perspective of looking at muscle testing. So and a lot of times, because muscle testing actually takes a lot of time, it takes patients, they have to undress, get on a table and so forth, and then in the era of this HMO where you have to see patients every 15 minutes, 10 minutes and so forth, if it's done very minimally.
Rudimentary, yeah.
Right, it's kind of like, okay, can you lift your hands up, and okay, can you do this? But, that's about how it goes, but you'll be able to see that we test each muscle with the understanding that we need to know what that muscle can do. So we could recommend, for example, how much exercise you can or cannot do. Whether you need braces or not, and we're answering these very fundamental functional questions based on this muscle testing. So that's one thing that we get, and it's always double checked by Dr. Perry, because the therapist, might put a bunch of numbers on there. We watch him walk, and Dr. Perry would often say, "I don't think that quad is a 2," And sure enough, we have him go check it again, and it's not, So it's a really quality controlled muscle testing, not just, anybody doing it. And
Dr. Perry, you have to live forever. You know that, don't you?
I think so.
and some of the residents and stuff, or they sometimes do their own muscle testing, and we tell them, no, that's that can't possibly be right, because this is what we see, and they're kind of amazed at how Dr. Perry would know that, and she has not even seen the patient yet, So
after X amount of years, I suppose you just know.
Well, that's right. And function has certain minimum requirements on strength.
Right. So the muscle testing is one of the fundamental basis of our evaluation. And the thing is, it's and as you know, one of the hallmark of polio is that you have the range of disability in polio is from 0 to 100%. So, and anywhere in between, it could be, 55.7% disability, and the next person is 55.2. I mean, and it's very distinctly different. It's very difficult to group them together. And the only thing that for us that we could use to quantify, okay, what does this person can do that this person shouldn't do? In some cases, we tell our patients, you need to exercise more because you got weak because you're deconditioned. And in this person, you got weak because you're working too much, you're going over capacity. But you can only give these individualized recommendations based on these individual muscle testing. There's actually just no way around it. I can't look at you and say, I think you need to not exercise, or I think you need to exercise. I mean, it's even to the specific as to, you could exercise this left leg, but not the right one, or, And that only can come from an accurate muscle testing of the entire extremity. So you really can't make a blanket post-polio syndrome recommendations that will fit all people. You really need to have it individualized, and so that evaluation and a thorough evaluation that incorporates muscle testing is probably one of the most important things you can do.